Hello and welcome to the Brain and Transcranial Photobiomodulation Virtual Summit. I'm your host, Dr. Joe Doduro. My guest today is Dr. Robert Hedaya, and he's a clinical professor at Georgetown University School of Medicine. He's a faculty at the Institute for Functional Medicine, and he's really been on the cutting edge of medical practice, psychiatry, and psychopharmacology since 1979. With the publication of his first book, Understanding Biological Psychiatry. He's also pioneered the use of functional medicine in the psychiatric field, and now is pioneering the use of QEEG-Guided laser treatments for neuropsychiatric disorders. As a clinical professor at the Georgetown University Medical Center, he has been awarded Teacher of the Year on 3 occasions, and is also one of the faculty members of the Institute of Functional Medicine. He's been featured on local and national media like 60 Minutes, 2020, and the New York Times. It's my great pleasure to welcome you to the program, Doc.
Thank you. Thanks for having me, Joe.
I guess the question is, it's good to see, with you with a little bit of gray hair. I mean, you've done a lot. You've been doing this for a while. Tell them a little bit about your story, about how does a medical doctor trained in psychiatry, start to implement functional medicine and everything, and then get into transcranial photobiomodulation. Give us a little background.
Okay, I'll try to give you an overview. I was trained at National Institute of Health in Georgetown, and then I was practicing the regular psychopharmacology, psychotherapy stuff, and then one day I had a woman with panic disorder, didn't resolve, took a year to figure out that she had a B12 deficiency, gave her an injection, her panic disappeared. I was like, whoa, what else am I missing? It looks like the head is connected to the body by the neck. That's very interesting. I missed that lecture in medical school. And so I went on to figuring out all the things in the body that affect the brain. And of course, that leads, to functional medicine. Ultimately, originally it was called metabolic medicine, then functional medicine. And so I was in the first, I think it was the second class of functional medicine with Jeff Bland, and then really pioneered it in pushing it really at Georgetown and pushing it by teaching through Institute for Functional Medicine and lecturing, et cetera, and wrote a couple of books on that. And then probably about 2 years ago, actually retired in 2014, got really tired of the administrative stuff. And then, just started going to conferences and reading and following my interest. And about 2 years ago, roughly 2.5 years ago, I was on a vacation in Arizona, lying under some trees on a hammock and reading a book on How the Brain Heals by Deutsch. I'm reading about lasers, and I'm like, wow, this could really help the brain, getting that ATP boost could be pretty amazing, right? But I started to think well, how exactly would you do it, and et cetera. So I started investigating different types of lasers, reading the literature, et cetera, and decided that really what made the most sense to me was to, as we do in all of medicine, you have to know what the tissue is doing. You have to know where to apply and what to apply and how to apply it and how frequently to apply it, et cetera. So my basic approach is to treat the terrain, meaning the body, and then work on the brain. And so we work on the brain with a few different things, but one of them is the photobiomodulation using the laser. And
so really, in 2 years, you've advanced this style quite a bit to find the location and then the treatment, because you were looking at how much am I supposed to do this and where am I supposed to do this to get the good results.
How much, where, how frequently, et cetera. Plus, you got to prepare the brain and the body, right? You have to prepare them
for these interventions, because
right.
It's a lot of people are doing a treatment, and then there's others who are treating for an outcome, and that's the difference between the practitioners and people who are kind of masters of it. So your idea that take vitamin B or take vitamin C or these sort of things, how was that interpreted by your colleagues? Because, because if I can say something, Georgetown was one of the first to use the title integrative medicine. And since you're right around there, and I participated in a couple of these integrative medicine conferences, and all these Georgetown models coming up. So you must have been one that was kind of pushing that along, huh?
I've been pushing it along. I've been teaching there since '83, co-teaching with a colleague of mine, and one of the students once asked him, they said, Dr. Goldstein, what do your colleagues think of what Dr. Hedaya is promulgating? He said, well, he's out on a limb, but we're slowly crawling out there towards him. So I don't think the limb is going to break.
Attaboy. That reminds me of the story of the doctor. He had cancer, and he goes to Mexico, and they give him IV vitamin C. So he gets all excited, and he comes back. He started to tell all his patients, hey, this IV vitamin C, it's the way to go. And his colleagues are like, hey, you got to stop doing that. And he goes,
right.
Would you prefer that I died?
Right. It's pretty, this is what we deal with. But look, everybody's got their place in the world, right? We need the people who are stable, and we need the innovative thinkers. We need both.
So what in your practice, what is it that you see? Who comes to see you?
So I really see a very wide range. I mean, the typical psychiatric stuff, but really, the chronic fatigue, the fibromyalgia, the dementia, Parkinson's disease, neurodegenerative diseases of all types. I've got a woman now who I'm treating who's was losing one or two cognitive functions a week. Her losses were progressing so rapidly, but she was very motivated, got on her program very, very quickly, and we've stabilized her, and she's actually recovering functions. So we see all kinds, anything that's chronic, really, autoimmune disease, chronic fatigue syndrome, really, because the functional medicine applies broadly.
Okay.
What I have found, however, is that the functional medicine, while the patients feel better, the functional medicine doesn't really change what's going on in the brain itself very much. And I can tell that because I can look at the baseline QEEG, and then I can look at the QEEG, 6 months into their program. They're feeling really well. And I'll show you a case where someone was feeling very well. But when I did the QEEG, I saw what was going on. And
so let's jump into those slides, huh? Show us
yeah. First. And there we go.
QEEG and the algorithm-guided precision cerebral optimization. I like that. Is that TM behind that?
Not yet, but
you better hurry up. Not a lot of people. Hurry up. Go ahead.
Okay. Yeah. So I'm trying to switch the slide here, but it doesn't seem to want to switch. There we go. Okay. Okay. So this is the first case. This is a guy who was 24 years old. And anybody would diagnose him as paranoid schizophrenic. But if you talk to him, you would be like, this is a regular guy. What was happening to him, he was hospitalized a couple of times. He was psychotic, literally psychotic. And it turns out that aside from being obsessive, he was having distortions, visual distortions, where he was seeing people's faces and thinking that they were looking at him in a demeaning way or disdainful way. And he thought that he himself must be making some kind of face to precipitate that. So he actually got into something that was called lookism, where the idea is you can control how people respond to you by how your facial expressions. He became obsessed with that. Well, eventually, so I put him through the functional medicine stuff, and we really had to work very hard on his methylation, and that took about 14 months to straighten out, and his diet was poor, et cetera, et cetera. But then he came to me from Arizona, and actually what I did is I did the QEEG, and we found a number of things. But what you see in this place here, you see the yellow line here, right here?
Uh-huh.
Maybe I should orient people actually before, in case they haven't seen a QEEG. So, oops. So this is the front of the brain here. The eyes would be over here. The ears would be over here. This is the back of the head over here. And this yellow line is showing the connectivity between some area here, a particular area in the prefrontal cortex, and an area here moving towards the occipital cortex. And this is the right inferior longitudinal fasciculus. And we could look at this in a different way where you would see a nerve tract here. And then here we have the right vertical occipital fasciculus. Now these two fasciculi actually control the connection and information between vision and faces and reading and emotion, okay? So I spent hours really going over his QEEG and isolated these as these tracks which actually fit with his symptoms. And what you see here on the left is his brain, the same cut basically after 4 treatments. Okay, and the clinically what we have is that he actually described. We did 2 treatments a week, and he actually described that the visual distortions that he was having were starting to break down, meaning he could see that they were actually not really making sense. I explained to him that he was like, when I saw this QEEG with these pathways here, I said, you are like a colorblind person. I would not send you into my home to decorate my home because you don't know what the color red is. And in the same way, you can't really read a face. So meanwhile, we treated him and specifically targeting these tracks, okay? That's the important thing. Very precisely targeting the Brodmann areas that were evident here with specific frequencies. And by his 4th treatment, he said that these distortions were breaking down, and he could see that they were in fact distortions, and he actually came to believe that he was having distortions because he could now logically look at what he was seeing, see that it didn't fit with the other signals that he was getting. I just spoke to him yesterday, a month out after the treatment, and he no longer has any of those visual distortions. This has been with him since childhood, and it's gone. It's gone. And that's consistent with what we see when we use the laser targeted, that over the course, when we finish the treatment over the course of a month, we see significant improvement.
So, Doc, for us novices, like I said, I took my QEEG training in the late 90s. So this is more advanced, as updated software and everything like that. But the pre is on the right-hand side and the post is on the left-hand side. What are you looking at with your target there? When you looked at, what's the difference that you see there? Because I don't see the fasciculi and stuff. What did you see as the difference there? Is there anything we can?
You don't see it? You can't see it?
Here I can, but in the post, I'm saying I have the red crosshairs at a different section. What?
Oh, don't look at the red crosshair.
Oh, just look at the brain change.
Look at the brain, and what you see is that fasciculus here, that's the vertical fasciculus. The right vertical occipital fasciculus is completely normal, therefore it doesn't show up.
Okay. All right.
Okay, and the right and the right inferior longitudinal fasciculus, which is the yellow here,
Yep.
is now completely normal, so it doesn't show up. This means that those pathways, which are not really related to the basal structures in the brain, those pathways are now normalized, right? And it's reflected in his clinical condition. And by the way, as I mentioned, that one of these, the longitudinal fasciculus, is involved in reading. He happened to mention to me that his reading speed seems to have improved dramatically. And now I didn't tell him about that, so that was confirmation. But just yesterday, I actually spoke with him. We had an appointment, and the visual distortion is completely gone.
Perfect.
Now, they could come back if he has some kind of underlying process. For example, if he was 80 and he had a dementing process, then they could come back, right? But he's young, and I think there's a reasonably good chance that they won't come back. So that's one case. Now this was a treatment that I laid out in 3 steps, targeting specific areas, different tracks based on the diffusion tensor imaging in the QEEG.
Got it.
Okay. So this case here, this is a woman, a 56-year-old woman who had a large, very significant family history of dementia. And she had mild cognitive impairment. She had temporal lobe seizures, meaning little absence seizures. And she also had prosopagnosia, which is difficulty recognizing faces. So what you see in this slide here, on the top are eyes open and eyes closed. Left is eyes open, right is eyes closed, QEG, before treatment. And on the left, you see the QEG, eyes open on the left, eyes closed on the right, after treatment. Now, what's most, I mean, you can see obviously the areas of hyperactivity here, areas of hypercoherence where basically the way I describe it to people is hypercoherence is like someone screaming in your ear, very loud and very fast. You don't really get much information. You kind of know something's happening, but it's really poor efficiency. And hypocoherence, which would be the blue lines over here, is somebody whispering in your ear. You think you know something's going on, but you're really not getting any information. Either case, there's a poor quality of information. So you can see at the baseline, there's a lot of distortion in her brain function. But the most important thing, I would say, would be her right up here. This is the hippocampus. This is the memory center, memory consolidation center, right at the crosshairs here, right over here. Okay, and she's 2.7 standard deviations from the norm here, and after treatment down here, she's at 0.4 standard deviations from the norm. Basically, she's normal, and it's quite remarkable. Now, this is very targeted treatment, so we layered on what I call functional cellular optimization and FCO, and then we did the precision treatment with the laser and some training, brain training games, etc. And her business, this is a woman who's in business for herself. Her business expanded. She's hired employees, and most importantly, most impressively, her prosopagnosia disappeared. She can now recognize faces for the first time in 7 years. So
wow. So that's a APO. She has a double genetic predisposition for dementia. She started to have her cognitive decline in her late 40s. Do you have like the other like her MMSA or her MoCA scores changing? Did you have all her clinical cases stuff also? I'm sure you watched that.
I have it, but I don't have it with me. But she was mild cognitive impairment, and I think, if her MoCA was normal is 30, really, she might have been 28 or something like that. So it was almost subjective cognitive impairment, but there was some objective problem. And then we actually repeated her Cambridge face recognition test, and she had normalized on her Cambridge face recognition.
Can I ask you another? While we have this beautiful picture up there, I'd like to ask you, like, you see a hypercoherence in the posterior parietal zone, right?
Mm-hmm. Right.
Isn't that that's kind of indicative of? Is that kind of the MCI thing, or isn't there like a hyper coherence? Does it move as you get worse into your dementia?
Yes. Well, it depends on the type of dementia, and the location varies, right? So if you have a Lewy body dementia, for example, you might see something similar to this right here. You can see my cursor?
Yes, sir.
Okay, right here you'll see this. And then in the front of the brain, you might see hypocoherence, almost see two different regions, for example. She doesn't have a Lewy body, though. She has more of the ApoE4. And then she, also importantly, she also had this seizure thing, and you can kind of see that here in the temporal lobes, right? And that's kind of characteristic of what you might see in somebody who has a temporal lobe seizure disorder, which really cleared. I mean, this is a case of I actually wrote up a study with Joel Lubar on this, and we're waiting to publish it. But this is a case where not only did the hippocampus normalize, her seizure cleared, and her prosopagnosia also cleared.
Just on the outside, what was the total time under your care?
Well, she's still under my care, so it's been about a year and a half so far.
And the pre and post of these are like what time period?
I'd say it's the whole thing is maybe she was on the functional medicine piece of it for about 5 months, and then the brain stuff was about 3 months.
And how many treatments did she get applied to her?
She had about 25 treatments.
Very good. Thank you for that, Doc.
Yeah. Now the thing with this is a woman who has the ApoE4, right? So my job, as I tell her, my job is to make sure that you don't progress to dementia. We got to stay on top of this, right? So you're watching her, But this is evidence, I think, pretty strong. It's only one case, obviously, but pretty strong evidence that that these treatment approaches, if they're precision targeted, can actually do tremendous things. Now, the thing I was telling you before, remember this top portion here is after the functional medicine.
Right.
Right? So the functional medicine, she was feeling great. She's like, I'm going to the gym, I'm feeling great, I have energy, etc. But her brain wasn't doing so great.
So do you know if the question I have, if you have a hypercoherence and we're reading sort of the activity off of the brain, is that like a hyper action? Because if you gave someone vitamins or supplements, and they got energy, would you make this coherence worse? Would it be because it's already strong? I mean, is that one reason why her brain didn't reset, because it was already fired up?
Great question. So the hypercoherence means really that, these neurons are firing in sync, a little bit too much in sync, right? So I'm not sure that it's so much of an energy thing. I think of it actually more as of a compensatory type of thing, that her brain is working harder in these areas to try and compensate for other areas that are not functioning. That's kind of how I would think of it, because actually here she's still on the same functional medicine program with the vitamins and everything, and see she's much more it's a different brain.
If I could quiz at you, or give you tell me what you think about this, if you could, that your objective when you applied the transcranial photobiomodulation via a laser was what? When you see a hypercoherence like this, what is your objective? Because you know where you're going to put it, but what is your objective? What are you trying to accomplish yourself?
Well, you're targeting, the key symptoms, right? And in her case, it was the prosopagnosia and her memory, right? And the absence seizures, right?
Right.
And so the truth of the matter is that this was my first case.
Patient zero?
This is patient 0.
And you caught the lightning in the bottle. Good job, Doc. Good job.
I have to tell you, Joe, my mind was blown. My mind was blown because after the first treatment, she came into my office to make an appointment for the next treatment. And she said to me, she says, "Oh my God, I remember the person that I remember his face, the one I worked with yesterday, and his wife, and the mole on her face, and blah, blah, blah." And her facial recognition was literally cured immediately and never regressed. And the reason is that she basically had neuronal tracts in certain areas of the brain that were in a liminal state. They were alive, they had a heartbeat, but they didn't have much more. And when you give them the energy, the ATP, right, then you get the activation, and boom, the light went on, right?
Cool.
So that was pretty mind-boggling. I never really expected the seizure disorder to go away, and I did not expect her hippocampus, which is so deep in the brain, to normalize. But you know, there are obviously downstream effects, et cetera, right? Okay, so the next one here. This is a guy who's 65 years old, mild cognitive impairment. And you can see here, what you see here is areas of underfunctioning on the surface of the brain. The blue area is underfunctioning. You see a lot of areas of underfunctioning and overcoherence, hypocoherence. And what we have here is really a map of the brain, the connectivity map. This is the right side of the brain. This is the left side of the brain. This is the cerebellum. And the areas that are in orange and red are overconnecting, hypercoherent, and the dark blue and the lighter blue are hypocoherent. In any event, this is highly inefficient. And this is at 1 hertz. These are the delta neurons that are firing in 1 cycle per second. And you can see this is obviously a brain that's pretty stressed. And we did with him was functional medicine, of course, and hyperbaric oxygen and hydrocortisone. This particular change from here to here is after I assessed his genetics, and there are 5 genes that are involved in the signaling of cortisol, which is the stress hormone for people who don't know. That when your adrenal glands put out this stress hormone, that signal has to be read by the nucleus of the cell. And there are 5 genes involved in that whole process. It's NR3C1, FKBP5, CRH binding protein 1, and CRH receptor 1 and 2. So we assessed his genetics, and he had a number of variants in these genes. And based on that, despite normal or low normal levels of hydrocortisone cortisol in his saliva over the course of the day, I gave him hydrocortisone and then repeated the QEG, and you could see the dramatic improvement. It's just very, very dramatic. Now, this guy also had a traumatic brain injury, and we treated that as well. And you can see that that's gone. And I'll show you, this is at 1 hertz, and this is the same guy. He also has a genetic vulnerability to dementia progranulin gene. And this is the same guy, okay? And you can see, the black is all normal. You can see his brain is virtually normal now. So that's this one. I don't know if you have any questions on this one.
But this is the post then. This is the post. Then you started to do you looked at 10 hertz. Is this still with the hydrocortisone?
So we use different frequencies, you know. Yeah, this is still with the hydrocortisone.
But then this is the post laser effect.
Well, this is post hydrocortisone. I would say is the biggest factor here because of his genetics. Okay, that's why I say that this is a terrain and brain thing. This is not just like, oh, I'm going to just use the laser. You've got to really look at everything. That's why I call it whole psychiatry. You know, you got to look at everything.
Holistic. This is a more holistic approach. So you took the hypoactive brain and you kind of chilled out the flame, right? That was going on. He could have other things going on, you know, mold or whatever, right? He had a hyperinflammation based on his genetics and everything like that. And then you gave him a little bit more of a boost with the laser. Is that what you're saying? You targeted where he had his boo-boo, right?
I targeted it where he had his boo-boo and the temporal and the right kind of parietal area. And then, but I would say that the hydrocortisone, this was a clear effect of the hydrocortisone. And the hydrocortisone doesn't, it reduces inflammation, but the cortisone affects about 30% of your genome. 30% of his genes were not getting the proper signaling.
Right.
It's a big deal.
That's that functional medicine layer. It's kind of like the special sauce on the Big Mac, huh?
I mean, there's a lot of pieces, and it varies with each person, you know. What's the special sauce for me is different than special sauce for you, you know.
Yeah, man.
So this is a guy who has 66-year-old, and this guy had a vascular dementia. And you could see here, his brain was quite underpowered, right? Quite underpowered.
Mm-hmm.
And this is hypocoherence, meaning all these areas are underconnected to each other. And the dark blue means very, very low connection. He was sluggish, had no motivation, memory problems. He had a lot of cardiovascular disease, strong family history. And what I did with him is I did functional medicine. I put him on an intense HIIT program, exercise, and I put him on HBOT, and I gave him how many laser treatments? Maybe roughly about 20 laser treatments, which we vary. You know, we repeat the QEEG. We have an algorithm that we've developed, and we're continuing to modify, obviously, so that we're varying the frequency, the pulse frequency, the light, et cetera, et cetera. And this is where he is, you know, after his treatment. And you could see, obviously, a tremendous improvement here.
And he's boosting clinically too. You see that, you know, you have the stuff.
Well, the guy texted me 2 weeks ago, and he said, I just texted him to see, hey, how you doing? And he says, my memory is my new superpower. That's what he said.
What? Wow.
So that was very nice to hear. This is the same guy, and you could see here, this was kind of midway through his treatment. But you see here, this is the salience network, right? So the salience network was really dysfunctional, both overactive and underactive. And you could see there's significant improvement in the salience network as well with this treatment.
Could you describe for me, you know, you're looking at different, I see that your program here is going to let you look at different frequencies or hertz of incapacity. Like here, I'm not working at this frequency. I'm hypo. So that's pretty cool, you know, to be able to, you know what I mean? You're looking overall, and then you're looking for specific slices. So you're getting an overall general picture. Can you look through the whole head with these at this hertz? Is that what you're doing? Looking
yes,
through the whole head?
You can look through the whole head. You can look from 1 to 30 hertz. You can look at specific networks. You can look at symptoms. And what I do really is I actually go even deeper. You see this here. You see that right here. This is a particular neuronal pathway. I want to know what this pathway is and what its function is. You know, so I'm going through all of these to determine which pathways are dysfunctional, and then I'm targeting them precisely.
Correct.
That's how I do it.
Can you explain something to me on the side here? I was told that psychiatrists are the only people who don't look at the organ that they're treating.
Well, that's Daniel Amen. He says that. Right. He says that.
And so look at you, right?
So maybe I'm not a psychiatrist.
Oh, whatever.
I was actually matched, Joe. I was going to be a surgeon.
Oh, well, there you go. Brain surgeon?
I was going to, no, not a brain surgeon, just a regular old surgeon. And but then I had a great teacher, and I just fell in love. I thought the brain, man, that I'll never get bored with that. You know?
I know. This is once you get on the brain, that's what this conference is full of. People who are just trying to understand it, you know, trying to break through. Good man.
Yeah, it's really important to, you know, I know that there's, one of my concerns is that in the photobiomodulation community, let's say, there's this low-level treatment, you know, with the LED lights and all, which I think, I don't know for sure, but I think there's some penetration. I know Henderson says he doesn't think so. I think there might be based on some stuff that I saw, but what I'm talking about here is at another level. That's kind of like the CVS thing, and it can help some people, I think, because it's a generalized, low-level kind of thing. Take an aspirin, you have some pain, something like that. But what we're talking about here is very precise, very targeted, very personalized, monitored. We want to know what the tissue is doing, what it needs, and that's how we do it. So it's a dialogue between the tissue and the clinician.
And the stimulus. But let me ask you this, because a lot of people and a lot of psychiatrists and a lot of just regular people are running around with high-powered fill in the blank. So you have a high-powered laser, you have a high-powered ultrasound, you have a high-powered electrical stim, or you have these gigantic magnets that you stick your head in. Now, those people are just turning on the power without any type of diagnostics. What is your opinion about that? Okay, so you gave us your opinion on low-level activation. What is your opinion if somebody's going to take some of these cases and just kind of put a blast in them? Is that what you're seeing, or am I misunderstanding this?
No, I think you're right. Although I think I'm reading in the literature some evidence now that people are starting to look before they treat. But that's, to me, that's where it's got to go. You got to look before you treat, and then you got to know what to do.
Didn't we take the oath, right? First, do no harm.
Yeah. So that's this one, and that, I guess, was the last one.
Well, thank you, Doc. At least I popped off a couple of questions in there.
Yeah.
While we have a minute, I like to see that I have a nice gray-haired fellow in front of me. Do you have people under you that are continuing this work? Do you have a team of people that are going to go forward with this type of stuff?
You mean because I have gray hair? We've got to make sure.
You're already retired twice, so.
Just once. So, we're working on that. We're working on that. This whole Corona thing has really put a wrench in the works, But there's a group of people who have formed around this. They're interested in what I'm doing. And that's the idea, is I need to get this out there and because I think it can have a lot of utility for a lot of people. Can
you turn your lens the other way, as we like to say? I mean, you're looking deep. You've been looking at the brain. You've been looking down the pipe of your work for the last, almost 30 years. Look to the future. Let's say, I know we're going to do more of these because they're so activated, but now you and I are sitting at the 2030 Brain and Transcranial Photobiomodulation and Virtual Summit. What do you see? What is the field going to look like at that period?
Well, I hope that it'll be more widely distributed and that people will know how to read what's going on in the brain and how to apply specific treatments. And I hope that they do it based on a base of functional medicine. The reason I showed you that hydrocortisone patient was because I don't want people thinking, oh, just, hit the brain with some light and that's it. No, it's not. Sometimes yes, and sometimes no. You got to really develop a full skill set. And so that's my hope, is that I hope to be able to train people to do this broad approach to neuropsychiatric, neurodegenerative disorders. 10 years is not a lot of time. And now that we've got the Corona thing going on, we're going to be slowed down for a while. But I'm going to use it as a time for planning, and
participating.
Yeah.
Well, thank you for your time, Doc. Thank you for your input. Thank you for your expertise.
Thank you.